Okay, let's get started. So today my assignment was question 36 to question 40. So question 36, right? 40 years, a 42 years old man comes to the physician because of a 6 months history of a progressively worsening shortness of breath with exertion. And he was diagnosed with systemic sclerosis 5 years ago. And the vital signs are within normal limit. And physical examination shows puffy, taut skin over the fingers. And puffy, taut skin that means skin is very tight. And the pulmonary examination is unremarkable. And there is no jugular venous distension. An X-ray of the chest shows enlargements of the pulmonary vessel and prominent right heart border. Cardiac catheterization shows the high right ventricular pressure and high mean pulmonary artery pressure. The normal range was 10 to 14 millimeter mercury. And the treatment was tadalafil. And the question is, what's the expected beneficial effects of this drug on this disease? So before we start to analyze this question, I want to have a quick review of the systemic sclerosis. And on the FA, so there's a new name with this disease with scleroderma. And this was autoimmune and non-inflammatory vascular disease and with collagen deposition on the fibrosis. So here there's some symptoms which showed that in this question is on the skin. So you can see puffy and taut skin. So this is very characteristic, and we can see this disease can affect several organs like renal, like the pulmonary and the GI and our cardiovascular. So basically, on this question, we need to notify very concerned. This question was pulmonary hypertension. So first of all, there are two numbers we should memorize. The first one is the normal range of the mean pulmonary artery pressure. It's 10 to 14. And the other number is 25. So when the pressure is higher than this level, it'll be considered as pulmonary hypertension. So the first disease, that's very obviously, it's artery itself have some pathological process, and it'll be caused the artery getting more like stiff or like have more power on the constriction and less power on the visitation. So basically, there are two mechanisms. So the first one is when we have more, more substance would be cause the vessel to be constriction. So for example, if the endothelium getting higher, our vessel will be more constrict and the pressure will be getting higher. And let's say the other factor is vasodilator. Normally, vasodilator, of course, would be cause the vessel to be dilate. So if this kind of substance getting lower, for example, the nitric oxide getting lower, and or the prostacyclin getting lower. So our pressure will be getting higher, and so this will call this disease. Okay, so this is artery itself. So let's say the other disease. Let's take a look at this picture. Okay, so the first one as we just discussed. So this one is the artery. This one is pulmonary artery. If the artery itself, the substance of, let's say, the vasodilator getting lower, and the constrictor getting higher, so this vessel would be pressure would be getting higher. So actually, this is two mechanisms when we treat the disease. So this one we will discuss later on, but this is mechanism. We just use some drugs or some medications to increase, let's say, increase the dilator, or decrease the constrictor. So this is the main mechanism of the treatment. I mean, the drugs can treat this disease. Okay, so let's see. Except this vascular itself have some disease, the other pathological process, including, let's say, if we have some heart disease on the left side, and here the pressure getting higher, so the blood would be go back. So finally, this will affect the pressure here and getting higher. So this is a second disease on our FA. It's a left heart disease. For example, it'll be including the systolic or diastolic dysfunction, or some valvular disease. And then let's look back. So when we have, let's say, have some disease, let's say have some chronic lung disease, and it causes the hypoxia. And all of this disease would be increase the pressure here. I mean, the pressure in the capillaries. So for this kind of disease, we can imagine like the COPD or the other infections. Okay, so here, lung disease or hypoxia, destruction of the lung parenchyma, and lung inflammation and fibrosis, like the interstitial lung disease, and the other disease, like obstructive sleep apnea, and or living in a high altitude. But anyway, the principle is if the lung disease affect, let's say, make the vascular getting constrict, or have less oxygen, it'll be cause this hypertension. I mean, pulmonary hypertension. Okay, let's see if the patient has recurrent microthrombin. So that means, let's say, the emboss from the deep vein of our, let's say, leg, and it'll be go back with the system vein, And finally, it'll be, let's say, on our pulmonary vascular system. And let's say here. So we can imagine that the functional vascular will be getting, the quantity will getting lower because a lot of vascular has been blocked. So that means there's no function. They cannot do the oxygen diffusion or some exchange the oxygen, like for that means in other words it says it'll be decrease across sectional area pulmonary vascular bed. So that means the functional the real vascular has function will be getting lower, getting the quantity will be getting lower and lower. So the final one will be system. So that increase a lot of system disease like hematologic systemic or some metabolic disorders. One thing I want to add it was, let's say there's a tumor on the lung or on our pulmonary system. So it'll be compress the vessel. It doesn't matter here or here, but it'll be cause the pressure of the artery getting higher. So basically, this is pulmonary hypertension. Okay, so let's continue with the question. So this question asking us, so what with the medication tadalafil, to treat the pulmonary hypertension. From here, we already know there are two mechanisms we use for treat this disease. First of all, is if we lower the constriction, we can help to lower the pressure. And the other one, if we increase the dilator, it'll be lower the pressure. So for this medication, the mechanism is to increase the dilator and help the vessel to dilate. So and why this medication have this function? Because this medication is a PDE inhibitor. And so what is a PDE? And it's a phosphodiesterase. So this enzyme, the function of this enzyme is to help to hydrolysis of the CAM or CGMP. So in other words, this enzyme, the direct function is to decrease the CAMP and the CGMP. So with inhibitor, so that means it'll be inhibit the whole process. So finally, it'll be cause to increase these two substance. Okay. So let's say in the process of the increase of CGMP, it'll be increase the muscular, the relaxed smooth muscle, and then it'll be cause the pulmonary vasodilation, and that'll be beneficial for this kind of disease, for this kind of patient. So basically, except this disease we discussed, there are two other diseases the medication can be used. The first one, that's the priori. We use in China. and for several decades for this medication, especially the first one, sildenafil, is help to treat ED. And the third disease it can be used, and with this tadalafil, it's a benign prostate hyperphagia. So these three, the disease we need to memorize. So the other thing we need to focus is if, let's say, this medication have a side effect. It causes a blue tint vision. So this is very characteristic. If we see that in some questions, we will, find out they talking about this medication. And the mechanism is a PDE6. So okay, so it's for this question, we can get the right answer is E, because it can increase the visitation, and why this medication can increase nitric oxide. So let's see some details here. Okay, so basically the PDE5 inhibitor and the nitric oxide has a similar function. It will make the smooth muscle getting relaxed, and that means it getting vessel dilation. So let's say if we use this medication, use this PDE5 inhibitor, it'll be make this nitric oxygen, the efficiency, the effector time will getting longer. So it'll be help this medication's potential effects getting longer. So that's why this medication can enhance activity of the nitric oxide. So let's do more, discuss more regarding the treatment. So this PD inhibitor we already discussed. So let's say there are two other options we can use for this disease. The first one is endothelin receptor antagonist. So we already discussed this endothelin getting higher, so the vessel will be getting constriction, getting more severe on the constriction. So if we use some medication to against these effects, we can treat on this disease. So this kind of medication, including Boston. So this is a mechanism. It's competitive to agonism the endothelin 1 receptor, and it will make the pulmonary vascular pressure getting lower. So the other medication, actually the function of the other disease is to increase prostacyclin. So here we already So if the nitric oxide or prostacyclin getting higher, it'll be increased vessel dilation. So that's why we use this medication. Is Allonox. That means it's a similar function. So this kind of medication, including the amphoprostenol, and iloprost. And the mechanism we already discussed is here, a direct vascular in the pulmonary and the system other vascular beds. So it'll be, and the other function of this medication has can inhibit the platelet aggregation. Okay, so basically this is some medication can treat this disease. So the first one is A, and but this medication, I mean in the question, this medication belongs to E, is a PDE5 inhibitor. Okay, and the other one we discussed is this is second one, and this one, the third one. Actually, here it says the procyclin can be used as a vasodilatory effect on the pulmonary system, and it, on FA it will make it simpler. Actually, between these final effects, the PG has increases protein kinase A. Protein kinase A. So we can see from here. This is a procyclin. So they will stimulate the G protein, and getting more interlilate cyclase. So it'll be getting more cyclic AMP, and here it'll be inhibit this kinase, this MLC kinase, and finally it'll be get relaxation. And between this, there's another substance. It's a protein. It's a protein kinase A. So this we can get the clues from here. So let's say here, okay, the GS, the prostacyclin would have the positive effects on the stimulated G protein, and then it'll be increase this process, and finally get more CMP and getting more protein kinase. See here. So this is here, and it'll be inhibit this MLC kinase. So finally it'll be relax the vessel. Okay, so here is this question here. Let's have a quick review why we cannot choose the answer B. The answer B says decrease smooth muscle sensitivity to the norepinephrine. So that means this medication have the function to the alpha 1 receptor. That means it's a anti-agonist to the alpha 1 receptor. That's obviously is not a mechanism of this disease we already discussed with tadalafil. So here we can see norepinephrine. The function is alpha 1. The primary is alpha 1 receptor, and the final results of this medication would be increased blood pressure and heart rate, and increase or do not increase the output of our heart. So here we can see alpha 1 goes through the GQ, the Q, G protein Q, and it will be increase the phospholipase C, and this will increase the IP3 getting higher, and finally it will be increase the calcium inside the cell, and this will increase the construction of the smooth cell. So basically, this if we use some some blockers to block this alpha 1. So basically, so for example, this is alpha 1 selectively antagonist. So basically, it'll be used as the symptoms like the disease like BPH or PTSD or hypertension. So it's not the first choice for this pulmonary hypertension. And the other one is we didn't discuss was D and ACEI. So basically, ACEI is the it'll be inhibit ACE and decrease AT2, and GFR will be decreased too. So this is not cannot be used in this disease, and this ACEI we will discuss later on with more details. Question 37. An 81 years old man is admitted to the hospital due to acute decompensated heart failure, and he has a type 2 diabetes and hypertension, coronary artery disease, congestive heart failure. Current medication include lisinopril, metformin, and low-dose aspirin. And he has smoked 1 pack for cigarettes daily for 45 years. His temperature is 99.7, pulse 105, and respiratory are 21, and blood pressure is 103 and 64. And laboratory studies as below, and we can see that here the sodium is low, and glucose is high because the patient has diabetes, and the other abnormal is for the function of the renal. So we can see from here the patient diagnosis. First of all, he has heart failure, and second, the function of the renal was damaged. So patient's history, and this time, including this time, his heart failure. And heart failure will increase the blood pressure to decrease, and then this will cause some kidney injury. And on this kidney injury, this process is prerenal azotemia. And one of the evidence we can see from here is we use this urea nitrogen, the number of this urea nitrogen, and by the creatinine. That was That was that was nearly 26. So according to some diagnosis standard for the acute kidney injury, this is considered as prerenal azotemia. Okay, there are three acute kidney injury. So on this question, it'll be the first one. It's a prerenal azotemia, and the other two was post-renal azotemia and intrinsic renal failure. So on this question, let's focus on the first one. On the first one, okay. So under the the condition like on this question, it's heart failure that causes the effective circulating volume getting lower, and this will cause the low RPF. That means the flow, the blood flow on the kidney, and this is and it'll cause a GFR, aka glomerular filter rate. These two were getting lower, and for compensated, our body can make some makeup, so it'll be increased reabsorption of sodium and water and the urea, and that's why in this question we have lower serum sodium on this question. And the other very specific in this question is the urine. Here, okay. This serum urine nitrogen, and by the creating. Here we get the results of 26. So under that situation, it's another evidence on this question to support our diagnosis is prerenal azotemia. And I want to add more details for this definition for the Fe sodium. So what is Fe sodium? So it's a fractional excretion of sodium. And how to define this, we can see from this picture. So fractional excretion of sodium, that means the excreted sodium from our urine by the filtered sodium. So that means let's say all the sodium in our blood, and it'll be go through our kidney, and some of them would be filtered into our kidney circulation here. So finally, it'll be increase. Go through the whole process, and finally, part of them would be appeared in our urea. So this fractional excretion of sodium was the ratio of the excreted sodium and by our filtered sodium. So let's see a little bit more details here. So according to this definition, is amount of the sodium excreted from our urine, and by the amount of the sodium filtered by our glomeruli glomeruli. And the final equation would be urea and sodium multiply cerium, Cr, and by the cerium, sodium, multiply urea and Cr. So how we get this final formula? We can see from here, okay. So the urea, sodium, the amount of the sodium excreted from the urea, it can be shown as here is a urea sodium multiplied urea volume, and this will by the cerium sodium multiply the urea, the urea volume. Actually, here, why we need this? So it cannot be directly to calculate the sodium filtered by the kidney. So we have to use the CR, that's creatinine, to calculate the final filtered sodium. So here it's use the cerium sodium multiply urea creatinine, and multiply urea volume, and this need to buy the cerium creatinine. So finally, we get this one. So I think maybe some questions in the step one would calculate this, but the conclusion is when we get the FeNA less than 1%, it'll be considered as pre-renal, like in this question. And for the opposite, the FeNA, if it's greater than the 2%, it'll be considered as intrinsic renal failure. For example, is AKN. That means acute. That means here acute interstitial nephritis. So for this question, first of all, we get one impression for this diagnosis because of the heart failure, and we cause the low, GFR, and that means have the damaged function on the renal. So let's go back to the question. So on this question, which following changes in the medication regimen most appropriate in this patient at this time? So first of all, according to the analysis we just did, so first one we need to consider is this patient with a heart failure, and second as with acute kidney injury. Okay, so AKI, it's a pre-renal. So under that situation, it can, if we want to stop some medication, that means the medication has the side effect on the renal system. So if we, from this perspective, this question's correct answer was E, because metformin we will have the side effect on the renal system, and also this one, aspirin also have the injury. If we use in a high dose or long-term high dose. But however, in this question, we already have the information that the patient only have a lower dose aspirin. So the question for this question the answer for this question it'll be this would be cannot choose this one. Okay, and let's look at the other answer, the B, because here there is no any symptoms that show the patient, get the functional of the renal has been damaged because of the infection or any other like symptoms like a fever, or any other symptoms related to the infection. So this one would be exclusive. And the other three, let's look a little bit one by one. So the first one would be let's say, for example, if we only consider about the HF, so the first line we use the first line diuretic would be loop diuretic. For example, like furosemide. Okay. So let's say even under that situation, we still cannot use this diuretic, because on this question the patient has very low sodium. So under that situation, if we really want to use this this diuretic, we have to put more sodium to give more sodium by the IV. So it'd be so this is not the first line to treat this disease. Okay. So let's say for the nitroprusside. Nitroprusside, normally we would use on the regarding this nitroprusside, normally it'll be used in the hypertensive emergency. So under this question, the patient has the blood pressure is very low, so it's not appropriate medication. And the last one, okay, regarding to norepinephrine. So normally, let's say if the patient have very severe heart failure, the first one we need to consider as dopamine on the clinic. And for this medication, norepinephrine, normally we would use those very severe condition like under the patient need a CPR, or it's very weak on the pulse, or the on this systolic pressure ought to be lower than 70 millimeter mercury. So on this question, it's not an appropriate treatment. Question 38. A group of investigators is studying a drug that treats refractory angina, and this drug works by selectively inhibits late influx sodium ions into the cardiac myocytes. So at high dose, the drug also partially inhibits the degradation of the fatty acids, so which following is most likely effective this disease. To be honest, this question is very specific. So if we want to get the correct answer, we need to know what kind of drug has the mechanism, including the late influx of sodium ions and the degradation of the fatty acids. So under that situation, the whole books of the FA regarding this mechanism is one medication. Okay, so in our FA, so only this medication have this mechanism that inhibits the late phase of inward sodium current, and thereby it decrease the diastolic wall tension and oxygen consumption. So what that means, it's still very blur, and we need to have more understanding what's going on when we use this medication. Okay, so let's see in the normal situation. Here is a depolarization, and here is a repolarization. So under this repolarization, there is one process, physiological. It's on physiological process. There's a late inside sodium. So on the normal situation, it'll be getting the sodium inside from outside to inside. It's very low. So under that situation, there is one enzyme that exchange the sodium and the calcium. So sodium under that situation would be also from the outside to inside to make this sodium to keep the balance. So under that situation, the calcium would be go outside. So under that situation, our muscle will not have any, let's say, construction. However, when the late on the abnormal situation, the late sodium would get higher. And under that situation, because the increased sodium inside the cell would be cause this enzyme to pump more sodium go outside our cell, and in that case the calcium would go inside our cell. So under that situation, our heart muscular would get more constriction. So this medication we just discussed, this medication named ranolazine. Okay, ranolazine. Except the mechanism we just mentioned, there are another mechanism So we can see from here. So this one we already discussed is inhibit innate inward sodium channel on the cardiac myocyte and reduce the calcium influx via this sodium calcium channel pump and reduce the stress and the muscular oxygen use. So, okay, the other mechanism under this medication is it'll be decrease the rate use fatty acid beta oxygenation. So under this situation, it'll be use oxygen, and but this medication can increase glycolysis, and on this process, it'll be use less oxygen. So both of these two mechanisms, it'll be increase the oxygen's efficiency. So that's the whole mechanism under this medication. So the correct answer here would be choose A. Okay, so B, increased prolactin release. So what kind of medication have this side effect? So the medication related to the heart disease. The medication is non-dehydrated pyridine calcium blocker. And one example is verapamil. And the other mechanism could increase prolactin is, let's say, if the dopamine production has been C, decrease uric acid excretion. So the medication can have the side effect of this was low dose of aspirin. Okay, 重新来. Okay. C, decreased uric acid excretion. So what kind of disease, what kind of medication can cause this? It'll be aspirin. And under the low dose. And on here, we need to pay attention as aspirin have the effect to increase the fatty acid oxidation. So on this question, it says partially inhibits the degeneration of fatty acid. So that means it's opposite. Okay, the answer D, decreased insulin release. So normally the medication can increase the insulin release, would be beta 2 blocker. For example, is a propranolol. Okay, so let's have a review of the normal situation when a beta blocker receptor. So normally, beta receptor would be affect on the GS protein. Okay, so let's have a review of this very high yield process. So here is a beta 2 receptor. It'll be affected on the GS protein, and it'll be increase the adenylate cyclase, and it'll be increase the CAMP, and then it'll be have more it'll be active the protein kinase 8, and then it has two main functional. So first one would be on the heart. So that's it's one main function for beta 1. So the other one is on the smooth muscle. It'll be cause the smooth muscle to relaxation. So this is a beta 2 function. So let's go back to here. Okay. So let's say the beta receptor under the normal situation, it will be affect the smooth muscle. So this is the main function. This is the most important, the smooth muscle. So smooth muscle in the blood vessel, or the bronchioles, or the uterus. So it'll be separately, it'll be affect the blood vessel to be vasodilation, and on the lungs it'll be cause the bronchodilation, and on the uterus it'll be cause the relaxation both uterus and bladder. So let's say on the liver, which is have the relationship with this question. So let's say on the liver, this will cause the liver have more glucogenolysis, which means it'll be increase the glucose. I mean, this will cause our level of the blood glucose to increase, and this also on the pancreas, it'll be cause the insulin release more insulin. So let's see from the picture here. So mostly beta 2 receptor would be increase the CMP on the smooth muscle, and smooth muscle on the blood vessel, or the uterus, or the lung, or the or the bronchioles. So it'll be cause all the function is a smooth muscle relaxation. So let's say on the liver, it'll be cause the gluconeogenesis or glucogenolysis. Both of these will be increase the glucose. So that's a normal function. However, if we block this, it'll be to like medication that block to inhibit the beta 2 blockers, beta 2 receptors. It'll be cause the opposite function. Okay, so that's why under this question, if we use this medication, propranolol, it'll be cause the insulin to decrease. Okay, so let's see the last. Okay, see let's check the E. It decreases serum pH. Okay, so let's go back to this question. It says it partially inhibits the fatty acids. So that means this on this research, it will cause this fatty acid oxidation be increased. So under that situation, it'll be cause some to decrease the keto acid. So it'll be cause the pH increase instead of decrease. Okay, so let's see the last one. Increase the parasympathetic tones. So for the medication can increase parasympathetic tone. The medication is a digoxin. So this digoxin, the mechanism that this medication can inhibit the pump. The pump named is sodium potassium ATP pump. So under this medication, the pump would be inhibited, and so this will cause the original sodium being pumped out has been decreased. So the sodium decrease would be affect when the other ions like calcium to pumped out. So finally, the calcium inside the cells will be increased, and finally because the heart construction has been increased. So this mechanism we can use as the mostly it'll be on the heart failure to increase construction of the heart. So this will cause a positive entropy. So that's the main medication we used in our clinical cases. So at the same time, this question, the question says one function of this medication is to increase parasympathetic tone. So normally it'll be increase because of increase the vagus nerve, and under that situation it'll be increase the parasympathetic tonic, and to decrease the heart rate. So, but obviously this medication, the mechanism has nothing related to the mechanism we mentioned in this question, like the late influx of sodium ions, and also the digoxin has no any related to the inhibit the fatty acid oxidation. So that's why we didn't choose this answer. Okay, question 39. A 55 years old man with a hypertension, hyperlipidemia, type 2 diabetes, and asthma comes to physician because of 2 months history of intermittent dry, hacking cough. He does not have fever, chest pain, or shortness of breath, and he does not smoke cigarette. Currently, medication include Vastatin, metformin, albuterol, and ramipril. His temperature is normal, pulse normal, and blood pressure is a little bit high. It's 142 and 88. Cardiopulmonary examination shows no any abnormal. Which following was the appropriate initial action by the physician? So basically, this patient have several diseases such as hypertension and hyperlipidemia and hyperglucose and asthma. So the patient takes several medications. So let's see, the metformin would be for diabetes, and the epidural would be for asthma, and simvastatin is for his hyperlipidemia, and ramipril as for his hypertension. So basically, because the patient has no any other symptoms, has no fever, and has no any chest pain or shortness of breath. So just a very, very severe history of the dry and cough. So I think this question is not, this question is not very hard to answer. So basically, the medication will be increase the cough, especially on the cardiovascular disease. It'll be ACEI medication, ACEI. So under this question, it should be the ramipril. So this is the most potential medication can cause this. So let's see, it's here. Let's see, we choose C. And all the other answers, let's have a review. And here, okay, here there's a 2 actually to stop this medication, but the other one we see Nisinol pril. It's exactly the same category, ACEI. So here it cannot use. So and under that situation, it'll be starting another medication, candesartan. It's an ARB category. So basically, this is this question. So let's see. Okay, so let's get in more details for this question. So first of all, why the ACEI medication can cause the cough? I think we discussed this before actually. So first of all, let's see the ACE. This substance normally it'll be produced in the organ like a lung or the kidney. So on normal situation, this ACE would be decreased bradycardia. So if we use ACEI medication, it'll because the bradycardia getting increase. I mean, if we use the ACEI, so this will cause this substance to getting increased. So increase bradycardia will cause the cough. So that's the underlying mechanism why this medication can cause the cough. So let's have a little bit review about this medication, ACEI. So it's include several the end with pril, such as captopril, enalapril, lisinopril, and ramipril in this medication, in this question. So normally, let's say in our physiological process. So normally, in let's say our liver. Okay, under our normal the normal process of our body. So our liver will produce some carcinogen, and this will be have the under our one substance renin, and it produced by our kidney. So under this substance, the original angiocarcinogen would be become the angiotensin 1, and under the ACE, it'll be become the angiotensin 2, and then it'll be affect most of our our blood vessel, the kidney vessel, and kidney itself, and angina, renal angina. It's indoor. OK， 这边听一下 adrenal gland. So under our adrenal gland and our hypothalamus, and then it'll be affect our and there will be have multiple function in our body. So when we use this medication, it'll be inhibit this ACE, and it'll be inhibit the angiotensin 2, and this will be decrease. I mean, the decrease the effective of the constriction. So that means it will be dilate. It will be dilate our afferent arterioles. So let's see here. In a normal situation, if there is no medication ACEI, so normally when we have this angiotensin 2, our afferent vessel on the so our glomerulus afferent artery would be constrict. So this will increase the blood to filter, going to our the tubes of our renal tubes, and this will preserve the GFR. So under the situation when we have the ACEI, it'll be inhibit this process. So that'll be decrease our GFR, and this will increase renin. The renin would be increased. So let's see what kind of situation the renin would be increased. So basically, if we have blood pressure getting lower, or let's say it'll be have a very sensitive on the detect the quantity of the NaCl on our muscular dense cells, or if we have a very high beta 1 receptor function on the sympathetic tone. So both of the three would be increased renin, and so this medication can be used as a hypertension, heart failure, or proteinuria, or the diabetic neuron disease, and it'll be have the prevent unfavorable heart remodeling as a result of chronic hypertension. So in the chronic disease, maybe this will be in the chronic disease, especially for the diabetes neuron disease, it'll be decrease the intraglomerular pressures and slowing the GBM thicken. So this is why we can use in the diabetes nephropathy. Okay. The adverse effects of this medication including cough, and the other one was angioedema. So both of these because of the bradykinin. 重新开 OK， 最后一遍啊。OK, adverse of this medication would be cough and angioedema. Both of these because increase the substance on the bradykinin. And the other medication, the other side effect we should focus was if the patient, let's say, have the artery stenosis, renal artery stenosis, and because this medication can decrease the GFR. So under that situation, it'll be getting severe renal failure. So under that situation, we should avoid to use this medication. So the other side effects, such as because of the GFR getting lower, so it'll have a higher CR, and we should avoid to use this medication for the woman have a pregnancy, and also this can cause hyperkalemia, because normally this under the normal situation, the potassium would be secretion would have been getting higher. That's normal. So when we use this medication, it will block this function. So in our body, the potassium would be getting higher. That's this medication. Okay, so let's have a quick review for why the other answer is not correct. So the A, it's start dextromethorphan, and this is one of the medication we can use as an antitussive. So what is antitussive? That means anti-cough. So in other words, this medication will not cause cough and it will treat cough. So basically, it's not the correct answer. And let's see this medication. Its a mechanism is NMDA glutamate receptors blocker. So this medication has very similar function as codeine, synthetic codeine, and so that's why this is have the mild opiate effect. So this medication have a little bit addiction potential, and then for example, when we have a patient, if they use this medication in the excessive too much, so the medication we can treat this overdose would it be naloxone can be used, and this medication can also cause serotonin syndrome. So if we combine it with other serotonergic agents like the medication that anti-depression. Okay, so and then it says increase the frequency of albuterol. So let's combine with answer E to explain this. So here it says stop, and here it says increase. The same medication, albuterol. So what is albuterol? Albuterol is one kind of the beta-2 agonist. In other words, it'll be have the increase effects for beta-2 receptor function. So under the beta-2 receptor, it'll have especially on our respiratory system, it'll reflects our subbrachial smooth muscle. So that's why it can be used as a treatment for asthma, especially for the acute asthma, because this is a short-acting beta-2 agonist. So, but anyway, if we increase this medication, there's no any function for cause the patient has more cough, and it doesn't matter stop or increase. So, and then here it says stop this medication, but starting another medication with the end with an arrow till, the EROL. So actually, ambuterol or somaterol, both of this medication belongs to the beta-2 agonist. So the only difference is the second medication is a long-term, it's a long-acting agent. So so this one, I mean the second one, can be used as, let's say, for chronic use, and the first one can for acute use. And so basically, this is why we couldn't choose the A or the E. So let's see why we couldn't choose the B. So the B, it says stop simvastatin, and starting atorvastatin. So from the name, we can see this is basically this is the same category disease with a statin. So statin is one of the medication we use to treat the patient have the hyperlipolemia. So especially with very high LDL. So the mechanism under this medication is inhibit conversion. I mean the HMG CoA reductase. So this is the enzyme that would be to increase, I mean to produce our LD fat synthesis. So especially for the LDL. So it'll be decrease LDL, and okay. So under this kind of medication, the side effect would be mostly it'll be the liver damage, and have the damage on our muscular system, especially when we use this medication with fibrate or niacin. Okay, this basically is for this question. So let's go back to, okay, question 40. A 55 years old man comes to the emergency department because of shortness of breath, palpitation for 3 hours. So he has a similar episodes intermittently for 4 months, and his pulse is 140 per minute, and the blood pressure was 90/60, and the ECG shows irregular, narrow, complex tachycardia with no discernible P waves. Emergent electrical cardioversion is performed, and patient revert to normal sinus rhythm. Pharmacotherapy with sotanol is began. So which following of most likely physical effect of this drug? So basically this question is asking what is the effect of sotalol have the effects on this disease. Okay, so basically this question is focused on this medication, sotalol. So let's say just from this medication's name, we can imagine this medication is a beta blocker. So basically, let's review a little bit. Let's say before we starting some specific medication, let's review some basic. So first of all, the beta receptor was has two located in two places. So first one is pacemaker cells, and the other is non-pacemaker cells. So let's say in the let's say on the pacemaker cells. So here we can see the beta one receptor is located on the membrane of the cell, and then if there is a epinephrine or norepinephrine to act on this beta receptor, it'll be cause the adenine cyclase to increase the process of ATP to transfer to CAMP, and the CAMP will be increased, and then it'll be active the pKa. So that means and this process will increase L-type calcium channels to open and increase the calcium inside the cells. So this when this function is on the pacemaker cells, this will be increase the phase 4 rate. And if this happened on the non-pacemaker cells, so this will have the function on the phase 2. So let's say because this so let's say this this medication is on the pacemaker cells. So why this happens on the phase 4? So let's review a little bit about the pacemaker cells. So here, okay, here, pacemaker cells. So the first step is a pacemaker's channel. Also, it can be named as a funny current. So it's a sodium inside the cells, and then at the same time, the voltage dependent T-type of calcium here would be open, and then this will increase the L-type calcium channel to open. So this will increase calcium inside the cells, and this phase would be here on the phase 4. So that's why we just mentioned on our last pages, and there's a phase 4 on the beta receptor function on the pacemaker cells. So let's go continue finish this. So after that, it'll be so after this calcium getting higher and higher, it'll be go to the phase 0, and this phase considered as a phase 0. So basically, after that, the pacemaker channel and the T-type channel, T-type's calcium channel would be closed, and then the L-type calcium channel will close too, and then the next phase is phase 3. So on this phase 3 is a is okay. 听一下. Okay, so the phase 3 is repolarization, repolarization. So, 听一下. Okay, so on the phase 3 is repolarization phase, and on this phase, it's basically it's potassium to go outside. Here to go outside, and finally it'll be the pacemaker channel will be reopened again, and this will be a cycle. So basically, this is pacemaker cells action potential. So let's go back to here. So on the beta 1 receptor, so we can see it basically it'll be have affection on the phase 4, and then when we have the beta blocker, so it'll be block the effect on the beta receptor. So this will cause the phase 4 getting lower, and at the same time, this will decrease the firing of the SA, and then it'll be decrease the heart rate, and at the same time, it also have the effect on our AV nodes. So basically, this is the this question's answer. So let's say this sotalol. Let's say if this medication we consider as a beta receptor blocker. So the first one, decreased AV node conduction, is a correct answer. So, but this medication is very special. And on our FA, it didn't calculate. It didn't. It didn't have this medication on the class 2 antiarrhythmic drugs, but on the class 3 category. So this is weird, but at the same time, that means this medication have the potassium. So that means this medication also have the potassium channel blocker function. So that's why it has been listed on the class 3 medication. So basically, class 3, we can see from this picture, the class 3 medication, we can see from this picture, it'll be have the long AP duration, and here, because it has block on the calcium, the potassium channel, and this will increase the repolarization. So this is the mechanism of this medication. So under that situation, it'll be have the similar side effect. So let's say the because of the QT getting longer, it'll be have the same situation like the other medications. It'll be get this very severe heart disease. Is a torsitis, depoints, and and this is one of this medication's side effect. Okay, so let's make a conclusion about this medication. Okay, let's do a little bit conclusion about this medication. So sotalol is a non-cardioselective beta blocker, and that also possesses a potassium channel blocker properties. And it is classified as a class 3. And due to its its function is a predominant potassium channel blocker effect. And so that's why this medication can prolong the action potential, duration, and effective refractory period in the atrium and the ventricle and the nodal and the exnodal tissues. For example, here we mentioned AV, and it is a potent competitive inhibitors for potassium current. And here it says sotalol exhibits reverse use dependent effects, which means that the maximum potassium current blocking effect occurs when the heart rate is slow. So this will increase the risk of QT. So that means the heart rate it's slower, and this medication's effect is getting higher. So that's why this medication have very high risk on the QT prolongation and torsades point side effect. And here it says a very low dose was enough to have the beta blocking effects, and for high dose it'll be have the class 3 anti-rhythmic effects. So basically this is this medication. It combines two mechanisms, including the class 2 and class 3. So okay, so let's see the other answer why we cannot choose. B, increased ventricular repolarization rate. So basically increase the rate. So that means decrease repolarization. That means the time for repolarization is getting faster, and that means the time is getting lower. I mean, the time is faster. So under this the medication it matched to this mechanism. It was a class 1B medication. So class 1B is a sodium channel blockers, and we can see from here. So on the sodium channel blockers, so here is a slower slope phase 0, and here we can see compared to the normal, the length of the AP getting smaller, and here the repolarization is getting faster. The time is getting faster. So basically, this is this mechanism. But the question, our medication is sotalol. Sotalol does not have this mechanism. Okay, So the C is decrease Purkinje fiber conduction. So basically, this is a very big category. So all the medications, if they have the if they have the function on this fiber Purkinje fiber conduction, it will be decreased. Normally it will be decreased. So basically, all the class 1 medications have this function. And still, the medication in this question is a beta blocker, and the beta blocker here we on this question, beta blocker is basically on the phase 4 of the pacemaker cells. So that's why we didn't choose this. Actually, I cannot confirm this because according to this mechanism of the sotanol, it has the function both in the blocker properties and the class 3 agent function, and this can be effect on the atrium, ventricle, and nodal and extranodal tissues. So among these tissues, I'm not sure whether this medication have the function on the Purkinje fiber. So this one I'm not sure. Okay. So D, increased myocyte entrophy. So the first medication we can imagine was digoxin. So digoxin was the mechanism was on the sodium and potassium ATP enzyme. So this has no any connection with the sotanol, and sotanol has no any function in inotrophy. And because this we already discussed before, so I don't want to make more details. So, okay, the number E, increased potassium efflux from the myocytes. So basically, this is a medication, adenosine. So under this mechanism, it's active the GI protein and inhibit the adenylate cyclase and decrease the CMP. And finally, it will be decrease the calcium to go inside the cell, and it will increase calcium, potassium to go outside here. So this will be increased. This one will be increased, and here will be decreased. So basically, this will cause more hyperpolarization. So what that means? So here, this phase is a hyperpolarization. So that means this one will be getting deeper, and that's why this will decrease the AV the speed of the conduction. So basically, this is the mechanism, and this mechanism have no any connection to the medication sotanol. So that's why. Okay, basically this is my the topics what I want to share with all of you. Thank you so much. Have a great day.